First of all, I would like to thank the organizers for inviting me and give me possibility to talk about the quality assurance in hypothermia treatments. And I will divide my talk in two parts. In the first one, I will discuss more in general what the quality assurance means in hypothermia and what is a good quality of hypothermia treatment. And in the second, I will touch more specifically the different hypothermia applications. So first of all, in the general introduction and discussion. So what does it mean, the quality assurance and control? If you look at definition, the quality assurance means the systematic actions providing adequate confidence that the quality requirements will be fulfilled. And the QA actions proceed the use of hypothermia systems. And the confidence serves then both internally to evaluate our treatments, but also to external parties, for government and insurance companies. The quality control is then a part of quality management focused on fulfilling the quality requirements. So the actions are during the treatment and concerns the use of techniques and actions to fulfill the quality requirements, but they are also after the treatment, and they help us to verify that the quality applied was correct and met the requirements. And the QA management is a perfect balance between the quality assurance and the quality control. And if you look on our hypothermia clinical trials, we can clearly see that the positive outcome of hypothermia treatment is strongly related to temperature increase and temperature achieved in the tumor. So we have some studies which were not successful, and we can clearly see retrospectively, also given by the authors themselves, that the low heating quality correlate with the poor treatment outcome. That the equipment was not able to reach the temperature to cover the tumor with the thermal dose prescribed. But there is even stronger and more evidence from the positive clinical trials that the treatment quality is positively correlated with the treatment outcome. So here we can see two examples, and I will follow the breast cancer study. And what we can see is, in the first example, that in the study of Scherer and Vernon, that if the thermal dose equivalent minutes at 43 degrees C was higher than 6 minutes, we can see the significantly higher local disease-free survival in comparison both with standard arm, but also with the low dose, the CM43 less than 6 minutes. We have two parameters in hypothermia, either the temperature or the SAR, the absorbed energy coverage. And if you look for this parameter, if the tumor is covered by more than 25% of the maximum SAR absorbed in the tissue, we can see that both complete response and local control is significantly higher than for the low dose scheme. And these were just two examples, and we can see many of these in literature. So hypothermia means really the temperature increase and in the tumor. Let's say. Now if you look at hypothermia treatment, ideally we would like to have a prescribed dose delivered by a black box. Just push the button and we would obtain the temperature increase. Unfortunately, we have a number of uncertainties which are related, and they are related just, some of them we can we can affect by ourselves just by choosing or selecting heating equipment we are using. But then we have also a choice of power applied, the frequency, and the water bolus temperature, etc. Another important parameter for QAs is the patient positioning. If the patient is placed according to treatment planning, and etc. But then we have other uncertainties which are not dependent on us or the equipment use, and that's the patient, and especially the patient response on heat, which is individual and can also vary within one patient in between the different sessions. And finally, what we need to measure is the temperature, and there are some uncertainties in that measurements as well. So the aim of the QA guidelines is to provide the user with tools to convincingly demonstrate the ability of equipment to heat the tumors in a specific trial. PTHO, European Society for Hyperthermic Oncology, created a technical committee for that. And we are a number of physicists across Europe, and also some colleagues from United States. And we are working on guidelines for specific hypothermia techniques. And for particular guidelines, we always invite the experts on a specific clinical applications, and often these are clinicians active in the field. And the companies are invited to provide feedback, but they are not actively participating on meetings or on writing process. So the role of the PTHO Technical Committee is to define a good hypothermia treatment and to identify hypothermia systems that can adequately heat the tumor volume for different tumor sites. Characterization of the equipment is, however, responsibility of every institute, and the data are given available to the committee, and we have a right to audit and site visit. So in this sense, the participation in PTHO clinical trials is open for any participant who implement the QA guidelines and who strictly follows the specific requirements of the study protocol. So this is a general. Now the question is, what is a good quality hypothermia treatment? And I have questions for you to consider. So I have now 3 options. And the first one is those that the T90, it means that 90% of tumor volume is covered by temperature 39.1 degrees for 60 minutes, and a median temperature T50 achieved is 42 degrees C. The second option is somewhat higher, T90, 40.5 degrees C for 60 minutes, but lower median temperature, 41 degrees C. Or the third option, the patient was cured. So I would like you to vote. So please raise your hands up who consider the A as the case. Would you consider the option A as a good hypothermia treatment? Sir? Low? Yeah, regional hypothermia, yes. So please, can you? No, so there is no one. Okay, good. Option B. Is there anyone who would consider B as a good quality treatment? No one? Okay. Patient was cured. We have 1, 2, okay, we have many. Nice. I agree in one way, because a healthy patient is our ultimate goal, of course. But healthy patient tells us nothing about the quality of the treatment. It could be another treatment modality who helped to treat this particular patient. Or it could be a miracle. So we need to have a practical definition which reflect the realistic demands we can require from current hypothermia technology. And for the superficial hypothermia, we ask the clinicians active in the field to define this and agree upon this question. And this is the answer. So the T90, 90% of tumor must be covered with temperature at least 40 degrees C for 60 minutes. And median temperature T90 should exceed 41 degrees C through the target volume. And the maximum normal tissue temperature should be between 43 and 45 degrees C. For deep hypothermia, the goal above is quite challenging with the present systems, so we can accept somewhat lower T90 as well as T50. For interstitial hypothermia, the goal is the same, but we must be aware of very steep thermal gradients and location of thermal sensors, because I will come to this later in the specific, in a more specific part of this talk. So, in light of this this answer, the B would be the case, because yes, we have T90 above 40 degrees C, and we have median temperature, let's say above or at 41 degrees C. What's wrong with the case A? Yes, we have a very nice T50, which means 50% of the tumor is covered with very nice dose of 42 degrees C. But we have low T90. That means that if we consider this is the tumor volume, we are heating very nicely half of the tumor. But we have low T90. That means that part of the tumor is unheated or heated very poor. And in order to achieve a good clinical outcome, we need to cover the whole tumor with the thermal dose. So by this, I will jump into the second part of my talk, and I will talk more specifically on recommendation for different techniques. Recently, we updated three major techniques in hypothermia: the superficial, the deep hypothermia, and the interstitial hypothermia. First, I will talk in general, what is general and common for all these three techniques. So the treatment delivery, the treatment duration is 60 minutes. And the treatment starts at low power, followed by stepwise increase of power during first 10 to 15 minutes. And what we require is to have a graphical user interface which shows the actual and history of power and temperature. Here I have an example. So here it's a temperature, tumor temperature, and critical healthy tissue temperature. And here we have output power applied. And here you can see the first, in this case, first 15 minutes, we had the stepwise increase of power, and that's related to temperature increase in the treatment. And what is strongly recommended is after the power is switched off, to record the temperature decay at least for 2 additional minutes. And the reason for that is that this decay gives you an information about patient perfusion. And you can use this information for the next session of the patient. When we discuss the staff, we have different professions related to hypothermia. We have radiation or medical oncologist who supervise the treatment. We have a physicist who is responsible for the technical aspect. Technicians performs the treatment supervised by clinician, and nurse who provides the support during hypothermia. And 2 responsible persons of any of these professions must be present during the treatment or be very available within 3 to 5 minutes in case there would be a problem. We require minimum training of staff in the form of active participation at established hypothermia center, and it includes around 20 or 25 sessions with a different number of patients. Treatment planning. For superficial and interstitial hypothermia, the only generic treatment planning is mandatory. And patient-specific treatment planning is applied at academic centers just to develop the generic guidelines and to increase the understanding, or to study impacts of specific anatomical structures. So for instance, here I have an example from Erasmus MC, when they have a patient with circulatory wire around the stern, and this could of course affect the treatment, because the fields, and cause the hotspots. So in this case, they simulated and modeled how to place the applicator in order to not increase the absorbed power and the temperature increase in that area. And yeah, they found it, and they treated the patient with success. For deep hypothermia, patient-specific treatment planning is mandatory. So we need to have create a patient model from MR or CT, and then to optimize electric fields and temperatures prior to the treatment. So now the specific recommendations for different techniques, and I will start with superficial hypothermia, which is defined as a heating of tumors penetrating typically not more than 3 to 4 centimeters. We recently, earlier this year, the guidelines were published, so you are free to download them, or if you are interested, you can just contact me. And what was the greatest challenge with these guidelines was the large variety of heating devices. Yeah, we have the standard radiative, electromagnetic radiative devices and capacitive devices, well known, but we have also ultrasound devices, and you could hear in previous talk the infrared device. And we need to find a way how to standardize the measurements of all these. And we come up with the criteria, which calls temperature rise for adequate heating. And here we have a fundamental requirement on heating system, and we consider it to be adequate if the temperature rise of 6 degrees C can be achieved at 1 centimeter depth in muscle phantom in 6 minutes. So you can see the rate 1 degree C in 1 minute. And if the system is not capable of achieving this, it cannot be considered as a good heating device, because in patient, if this temperature rise is impossible to reach in the phantom, you will never reach it in the patient with the perfusion. We have all the devices which are more superficial, and so for these, the criteria is the same, but for the depth of 0.5 degrees C. So based on this fundamental requirement, we can continue with 2 other different important parameters, and that's the thermal effective field size. So now we are in a horizontal plane in a 1 centimeter depth, as you can see here. And we consider the maximum temperature in this depth, and then we draw a contour around the area within the 50% of maximum. So in this case, the maximum was 7.6 degrees C, and then so the contour of 3.8 degrees C give us the thermal effective field size. And what is important that if we draw the aperture of the applicator, this thermal effective field size should be larger, ideally, because then we can place 2 applicators just beside each other to cover the large tumors. The second important parameter is the thermal effective penetration depth. And that's defined in the vertical cut of the phantom now. Again, we consider the maximum temperature at 1 degrees in 1 centimeter. And then we consider 50% of that, which is in this case 3.8 degrees C. And then we look and measure the depth. So for this particular applicator, the thermal effective penetration depth is 39 millimeters. It means that with this device, the tumors up to depth 4 centimeters can be treated. When we move on to deep hypothermia, we have again different techniques. And I should say that, now I will start with essential requirements. And these are that we have to focus, or we require the focusing of the energy distribution. And we also require the ability to steer the focus. And here I should point out that PTHO TC prefers the radiative devices, because here we can really nicely steer the energy within the volume, or the treated volume. Users of capacity systems should be aware and should be careful, because this ability to steer the focus is somewhat limited. The only possibility how to steer the focus here is to use the smaller electrode on the top, and then we can steer the focus up and down. So just to be aware of this. The characterization, we require the focusing. That means that if we have again a phantom, standardized phantom, then we require that SAR in the target, the ratio of absorbed energy in the target to the north target should be more than 1.5. And then this phantom also serves as for the periodical and reproducible QM measurements. So for phase steering check and field size determination, etc. The thermometry during deep hypothermia, if the invasive thermometry is used, the probes must be placed under the control of imaging device. In case of use non-invasive thermometry, at least one thermometry measurement must be carried out in regular intervals, typically every 10 minutes in the volume to be treated. And we require anyway at least one reference probe measurements. And finally, the specific recommendation for interstitial hypothermia. We will submit these guidelines during this year, later this year. And so first of all, what the interstitial hypothermia is, it uses the array of cylindrical applicators which are implanted into the tumor. And it's typically used with brachytherapy. Again, there are different techniques. I will not go to the detail. You can read it later in the paper. But I want to point out the most important points. And that's the implant geometry. We need to ensure that the implants are sufficiently spaced with a small spacing. Because if the implants would be too far from each other, we would have a cold spot in the middle. And the implants should be parallel aligned, because if not parallel aligned, there is a danger of causing either hot spots in the close or the cold spots where they are more far away from it. But when discussing the implant geometry in hypothermia, you don't have a great what to say, choose, because the implant geometry is already given by brachytherapy. And then you have your catheters, and you have to select which one you will use for heating and which of the catheters you will use for thermometry. And that could be tricky. There are two thermometry techniques. You can have thermometry either integrated with applicators, or we can have dedicated thermometric catheters. And what one should be aware of, that the temperature measurement will be then very different. Because if you have the thermometry in your catheter, close to your implant, you will measure the maximum temperature, because here around is the maximum field. On the other hand, if you have a thermometry or your thermometer in between, you will rather measure the minimum temperature. So you should be aware of this when reporting and when analyzing the data. The characterization of heating properties is similar to the superficial hypothermia. If we have an applicator, we will again decide the effective heating length. In this case, again, it is 50% of maximum of the maximum temperature, and this will give us, how large tumor we can heat with this specific implant. What is specific is that we never use only one implant. There are an array of applicators, and you must be careful, or you must be aware that you have an independent steering of it. So we have a check for that, and we haven't just decided on the setup. This is a last point to agree upon within the committee before the publication. So we will have the applicators placed either in a row or in a triangular setup, and then different switch on, switch off techniques, and it will tell us if the equipment works appropriately. So by this, I would like to thank you for your attention, and I would like to point out that the quality assurance is also our insurance. Thank you.
Thank you. First class presentation. Because I'm standing up for the following reason. What you have shown with the different applicators from different companies always faced an issue with the fact that we are not open for some other not recognized companies doing hyperthermia. And this is absolutely not true. You have shown now all the quality requirements to quote or advocate for one applicator to be sufficient, and this is independent of any company. Yep. So this is the very first step. Now the critical point I have is when you said a good hyperthermia has to cover the whole tumor, and you said 37 degrees in one part of the tumor would be no good heating. Okay, I tell you from a past experience in a large number of hyperthermia treatments, combining chemotherapy plus heat. Can you imagine that the complementary effect is important? If you have an area of the tumor which is not very well perfused, this is the area where the chemotherapy reaches target. On the other hand, if you have and this will be not heated because you have a perfusion and takes away the heat energy. On the other hand, if you have an area, maybe 30% in the tumor, which is absolutely not perfused, you don't get in this hypoxic area the drug on the place, but this will be heated very high. Mm-hmm. So what I'm advocating a little bit is when we have in mind what we call good quality heating, you're right, but don't forget the combination which gives you maybe another window of treatment, okay?
Yes, of course, I agree, I can agree more, okay.
Okay,
but
so
I would commend this that again, most of us comes from radiotherapy departments and not from a medical oncology department. So this is how we, how we define. Yeah, thank you.
Yes, thank you.
Not yet, I would say, because we needed first to update these guidelines, but it's a good point, and we will do, yeah, I think we will discuss it, and it's in the pipeline. And, yeah, but it also requires knowledge, so.
Okay, thank you.
Yeah, in the future.
I think that the both aspects...
The next one in pipeline is the treatment planning. That will take us a year or so again, maybe more. And then we will again sit down and discuss what is.